Assalamu alaikum students. This is a lecture on urinary bladder and micturition reflex. These are lectures in continuation of renal physiology. So the learning objectives of this lecture are basically threefolds. In the first section, we will be looking at the physiological anatomy of the bladder with its, along with its nervous innervation. In the second, we will introduce micturition reflex. What is it? What is its significance? How do we measure it using the systematogram? And at the last, we will discuss the various lesions, clinical scenarios of bladder damage and how they affect the micturition reflex. So this is not an exhaustive description of the anatomy of urinary bladder. It's in fact just enough information to give you an idea of what the bladder is like. So we call it functional anatomy. And as you can see, this is a very simplified diagram. You will get much more detail in your anatomy classes. This is like a ball-like structure the bladder is. We call it the body, which then comes to this narrow part, which is the neck of the bladder. So it gets continuous with the neck of the bladder. And the neck then passes through a thickened external sphincter, which is made up of skeletal muscle. We will talk about this. This is the urethra, which then goes out and is basically where the urine comes out of. This triangular area is called the trigone. This is in the lower lower part of the body of the bladder. This being the fundus, it's called the fundus, the elevated round shape top of the bladder. The importance of trigone is that it receives the ureters on its, it's like a triangle, right? So the broad base has two ends where the ureter comes in and basically drops the urine. This is where the urine comes in. So the bladder basically fills from bottom up. And then it is a good description in the sense that this wall, this muscle wall that the whole bladder and the trigone is made up of, then basically goes on to make the posterior urethra, the neck of the bladder, where there is a folding of the internal lining of the bladder. We call it the internal sphincter. And as we'll study, it's not a true sphincter. It's actually just a functional sphincter. However, it's important. So this is just a brief overview of the bladder, and the epithelium is called transitional epithelium. Again, you'll be discussing this a lot in your anatomy classes. But here it's suffice to mention that it's a very efficient, it's efficiently, the architecture of it is very efficient and clever. It's arranged in a way to not allow any seepage of water or urine into the wall. Also, it is folded from inside, making smooth folds called rugae. So when you stretch the bladder, it's actually the rugae which straighten out, and not the epithelium is not stretched. So there is no pressure in routine filling of the bladder. There is no pressure on the epithelium. So there is no chance of seepage, leaking of urine or water from inside the bladder into the blood. So this is the importance of rugae. The trigone, I've mentioned, it receives ureters on the top two corners, and the lower apex is continuous with the posterior urethra right here. Then the urethra passes through the external sphincter and the urogenital diaphragm right here, which obviously is longer in males and very short in females. And then last point on this slide is that the whole thing, the whole bladder, is basically made of a very thick muscle, a special muscle called the detrusor muscle. Okay. Now a bit more on the detrusor is that the muscle fibers are randomly placed. So this gives a lot of tensile strength to this big muscular thick wall, football-like structure that the urinary bladder is. and this random arrangement basically allows for symmetric contraction and relaxation of the bladder. If the fibers had been concentrically arranged or in a specific band-like thing, then the pressure inside the bladder when it were contracting wouldn't be symmetrical, i.e., almost equal from all sides, but it would be in bands. The pressure would also be exerted in bands, so that wouldn't have been very efficient. But since you have all sorts of crisscross like arrangement of the detrusor, when you contract the structure, so when it comes contracting in towards its core inside, the pressure that this random arranged muscle exerts is equal on all sides. Okay, so let's now talk about the internal sphincter. We mentioned that it's a continuation of the detrusor. It's not a true sphincter, which basically means that it is just a folding of the inner lining of the bladder, and it's not a specifically separate tissue. It's just the folding of the epithelium. It's not under conscious control, so it's just a thickening. It has a very important function in that the tone that it sets basically prevents urine from coming down into the urethra. So basically, this is where we're talking the internal sphincter. So whenever you have collection of urine at lower volumes, you don't necessarily want it dribbling down into the posterior urethra. A point about posterior urethra is that when you allow the urine to come down into the posterior urethra, the contraction, the micturition contraction, which we'll be talking about in a bit, they become strong. And there's a sense of fullness in the bladder, a conscious sense of fullness. So you feel like going to to empty the bladder. That's obviously inconvenient because at lower volumes, you don't need to go to the loo. So that's why internal sphincter comes in very handy in the sense that when it has it has an intrinsic tone, so it keeps the urine from dribbling down unnecessarily at lower bladder volumes into the posterior urethra. And actually, the urine keeps collecting here till it becomes significantly large in volume, and then a sequence of events start, which we'll discuss later in the lecture. So this is just there's an inherent tone that we spoke about and keeps the sphincter closed when the bladder is relaxed, i.e., in the filling phase. And this is the structure of it. So detrusor muscle, since it's all made up of detrusor muscle, when detrusor is relaxed, the configuration of the fibers around the internal sphincter are such that when the detrusor is relaxed, the fibers, they close the aperture of the internal sphincter. And when detrusor is contracted, it sort of tugs on or pulls on upwards so that the aperture, the internal sphincter, opens up uh, in that fashion, and hence the urine now is free to dribble down. Okay, so this is basically about the detrusor. Detrusor has a lot of stretch receptors, which are the mainstay of the micturition reflex, to be discussed shortly. And then we spoke about the internal sphincter and its importance in keeping the lower volumes of urine from triggering any sort of significant micturition reflex, and that conscious sense of filling of the bladder. So that's that. Okay. Now we talk about this is a UQ, a university question as well, the nervous innervation of the bladder. Um the urinary bladder is unique in the sense that the control involves both involuntary autonomic nervous system reflexes, mainly parasympathetic, and on top of it, it has voluntary control as well, as we all know. Children don't have it, infants don't have it, and they develop when they are being potty trained for the first 2 to 3 years. They keep wetting their diaper or their beddings because they don't have conscious control over their urination. But as they grow and the nerves are myelinated, they get control of their urination, and we will talk on we'll talk about this in this slide. So basically, the control of micturition, the control of the bladder is a unique mix of autonomic, subconscious parasympathetic drive and voluntary control, which comes directly from cerebral cortex. So let's just dive in and let's pick up proceedings from the bladder upwards. Okay, so this is the bladder, and it's being supplied by mainly by the sacral cord, sacral segment of the spinal cord, and also the thoracolumbar cord. The nerves are not shown here. Uh, so basically, the sacral cord, if you refer to this slide, which is basically a blown up part of this area. So this is the bladder, this is the sacral component, and you see parasympathetic fibers going into the bladder. This is the blue thing. They're going into the bladder. They're supplying the main bladder body. Then you have the same parasympathetic fibers going to the bladder neck, that the posterior urethra. So these are the parasympathetic fibers. Okay, they are part of the pelvic nerves, which go from spinal cord towards the bladder. Now, the same pelvic nerves also carry sensory fibers, sensory afferents from the bladder back to the spinal cord. So that's one thing to note. You see another. So that's the sacral cord, and that is this segment of the control of the whole bladder thing. The parasympathetic nerve fibers arise from the sacral segment of the cord. Then you have the thoracolumbar side, extended from T11 to L2. And as you can see, if you can correlate this with this diagram, it's the lumbar section, basically, which supply the sympathetics to the bladder. And you see that it's quite an extensive supply of sympathetics to the fundal area, the main body of the urinary bladder, and also the trigone area near the neck of the bladder. This is an important point which I'll discuss just in a bit. So as we are going from bladder upwards, we spoke about the sacral segment. Parasympathetics should come into mind. Thoracolumbar segment, sympathetics should come into mind. Then we go up, and here we see that at the level of the brainstem, specifically the pons, you have a maturation center here, which we'll touch upon later. And then you have the highest area of the CNS, the cerebral cortex. This is where the conscious control of respiration comes from. This is how you hold the urination when you don't want to go, and when you do want to urinate. This is where you control it from. So this entire network of control over the bladder is basically under the purview of your conscious control in the cerebral cortex. Okay. Just finishing off this whole diagram, this is a good diagram to learn how to draw. It gives you the location of the parasympathetics and the sympathetics. So these are the two autonomic nervous component of the bladder. You will also notice that lower sacral segments, there is a nerve coming out called the pudendal nerve, and it's going to the external urethra. So external sphincter, I beg your pardon. So we studied the internal sphincter just a while back, and now we're talking about an external sphincter. This external sphincter is actually a proper sphincter. It's made up of skeletal muscles, which is interesting because skeletal muscles are under conscious control. And indeed, the pudendal nerve is a somatic nerve. So this is where you, i.e. the cerebral cortex, control the overall emptying and filling of the bladder by holding on to the external sphincter. So if you contract this sphincter, the bladder will not empty and will keep on filling. And it's when you consciously relax this, we call it, it's a learned reflex, which we'll touch upon later on. When you relax this skeletal muscle, this sphincter, then urine is allowed to come out. Okay, so this is an important point to note. You have sympathetics, you have parasympathetics, and you have somatic nerve, all innervating the bladder. And these are the three levels of the control. This is another way of looking at it. The spinal cord reflexes, which is this and this. Then you have the micturition pons area, which has a part to play in this, and the highest is the cortical and subcortical structures, basically in the forebrain. Now, what exactly is the role of the parasympathetic and the sympathetic nervous system? It's an important point, and has to be obviously mentioned when you get a question on nervous innervation. So, very simply put, parasympathetics are basically uh, they contract the bladder. Okay, so they are motor in nature, and when they get stimulated, simply put, the bladder will contract and try to expel its urine out. Okay, so what do the sympathetics do? We will keep on mentioning the micturition reflex. Micturition reflex, very briefly at this point in the lecture, is these are reflex contractions which are incremental. So at low volumes, they are slight, they are less in their amplitude. But as the volume collects in the bladder, the micturition reflex contractions, they increase in amplitude. Okay, so this is going on in the background subconsciously. This micturition reflex, it's going on and on and on because the urine volume keeps on being added into the urinary bladder. So this is something that is at the backstage of the bladder functionality. Whether it will lead to a significant micturition reflex contraction, causing the person to feel the urge to now, go and urinate, that will depend on what the eventual volume of urine is and how aggressive these contractions are. Okay. So in that reflex, parasympathetics cause the contraction bit of the micturition reflex. Okay, more on this in a bit. Sympathetics don't have a part to play in the micturition reflex. Please make a note of this. Once again, sympathetics do not play a part in the micturition reflex, which is the mainstay of this lecture. So what do they do? A bullet point. There are two bullet points about it. Two main headings. One is they have a role to play in the filling of the bladder. Okay, I'll explain it in a bit. First, I'm just giving you the outline. So sympathetics, their function is in the filling of the bladder, and second is closing off of the urine flow into the urethra when there is ejaculation. So seminal fluids together with sperms, when they are using the urethra, you don't want urine to come in or the seminal fluid to enter into the bladder. So this is where the very important function of sympathetics come in. They close off basically this area here. Basically, this is where they are rich in supply as well. They close off this area so that there is no urine input into the urethra during the act of ejaculation. So they seal it off, and that's the second most important function. Going back to the filling function, if you look at the way they are arranged, they are numerous clearly, all around the bladder body. Okay, and then you have the supply on the trigon. So at rest, and note this, that we're talking now at rest, because they don't play any part in micturition reflex, which is about contraction and it's about emptying the bladder. So that is no, there is no role in that. But at rest, when the bladder is filling, what it basically does is it basically relaxes the detrusor so that it could accommodate more volume, and it contracts the outlet of the bladder right here. Okay, so it will contract the bladder neck muscles so that the tone of this internal sphincter is enhanced, and it shuts off any dribbling out of the urine. So the urine is basically trapped inside the bladder, and since its wall is being relaxed by the action of sympathetics at the same time, you have a pro-filling, quote unquote, effect in the bladder. So that's the function of the parasympathetic and the sympathetic nervous system in the urinary bladder. Then we go on to micturition. Now we start in micturition, and on the onset, we need to be clear that when we are talking of medicine and physiology, we need to make a distinction between the layman's term, which is urination or voiding, and the micturition. Okay, so let me just say it in simple terms. Micturiation is all that background, backstage. Uh, uh, how do I put it? Rehearsal of contractions, or a continuous process of volume being added into bladder, and that triggering a micturition reflex, which I mentioned here as progressive filling of the bladder. So as you add urine, as you add volume to the bladder, the wall gets stretched and it wants to now contract. And these are called micturition reflex contractions. And as you add more volume, the amplitude of these contractions increase, and the bladder, in simple words, wants to now get rid of this urine. It wants to. Not all wants come to fruition, right? So it just wants to do that at higher volumes. Obviously, this want will increase, which will duly be messaged to the higher areas as that feeling of wanting to go to the loo and void and get this urine out that we get when the bladder is now relatively full. However, urination will not happen. Micturition, you can't control. It's something that is inbuilt in the wall of the bladder, the detrusor. We'll talk about this. How is it a hardwired spinal reflex? And it just happens. You fill the bladder, it will give you micturition reflex. However, urination is that physical sequence of events which leads to voiding, which leads to passage of urine through the urethra and out of the body. So micturition is that backstage stuff which is giving you a signal that it's time, and it wants to empty the bladder with its contractions. However, urination is that physical act. So if you have guessed that it has to do with the external sphincter, the skeletal muscle sphincter relaxing, then you're right. It's that relaxation which is under conscious control, which is under your control, that causes urination or voiding. Okay, so this is an important distinction to make. The rest, I think, we have pointed out. Now, let's go into the nitty-gritty of the micturition reflex. It is an autonomic based spinal reflex, as we mentioned. The unique part is it is affected by higher centers. It can be modulated, it can be enhanced or inhibited, as we will talk about in one or two slides further. Let me repeat that. It is an autonomic spinal cord reflex integrated at the sacral segment. So bladder and sacral segment are in sync. They are one unit as far as the micturition reflex is concerned, and it has a very high dependency on higher centers, which keep it numb, which keep it inhibited most of the time. We're talking about adults here, not children, not infants. In infants, it's just gravity. Urine collects, and gravity will just pull it down, and off you go. Simple life. In adults, however, social appropriateness obviously is the call of the day, and the ability to hold on to urine volumes is important for our daily functioning. So the micturition reflex is arrested in inhibition by these higher centers till it's socially appropriate to go and empty the bladder. So the automaticity along with the conscious control is an interesting combination, and it's a necessity for our routine activities. And the components, we will discuss it visually in the systematogram later. But just to give you the components, that there are three components. So when volume is being added to the bladder, you have a progressive rapid increase of pressure. So when you have a micturition reflex triggered by the intravesical, vesicle is called, any hollow organ can be called a vesicle. So we are talking about the bladder. So when you are adding volume to the bladder, there is progressive increase in the volume, which will then at one point trigger the micturition reflex. And when it gets triggered, there is progressive and rapid increase of pressure inside the bladder. Then this pressure will be sustained for a short period of time, and then the pressure will be returned back to basal tone of the bladder. So this is a micturition reflex contraction. The pressure goes up, it stays there, and then it comes down back to baseline. Okay, it will be more clear when we talk about the systematogram. This reflex is self-regenerative. So once you trigger this reflex, uh, it doesn't need any external element now. It will just turn itself on and on and on and on, and it's just a cycle, progressive cycle that goes on. So bladder gets stretched by the accumulating volume of urine inside it. It causes a micturition contraction. Then again, the stretch is increased. Then again, you have a micturition contraction, and so on and so forth. This is what is meant by regenerative. It just that degree of stretch that keeps on regenerating the reflex. Okay, and it's incremental. So the previous, the preceding one contraction will be smaller. The proceeding one, the next one will be higher, and then the next one will be higher and higher. So you have an incremental pattern. Right. So this is a more user-friendly look at the micturition reflex. It's a simple diagram. It's nice. It gives you the two situations: bladder at rest when there is no micturition reflex going on. See how the bladder is relaxed. It's being filled. It's called the filling phase in this diagram. The internal sphincter is contracted so that urine doesn't come out into the urethra, which will obviously trigger micturition. And the skeletal muscle, the external sphincter is contracted tightly by motor neurons from the spinal cord. This is the pudendal nerve, and this is under direct control of the higher CNS areas. Okay, so this is what happens when you don't feel any urge to go. You're not voiding. Things are at peace, bladder wise. Okay, so then micturition is explained nicely in this diagram as well. You have a full bladder, much more fuller than it was here. The stretch receptors have been stretched. This sensory information, as mentioned, part of the pelvic nerves. So basically pelvic nerves has both fibers: sensory, i.e. afferents, and motor efferents, the parasympathetic ones, which I mentioned earlier. So stretch receptor, when it's activated by the stretching of the bladder, it basically sends down afferent information down the sensory neuron in the pelvic nerve to the spinal cord, and where it has a synapse, interneuron synapse on the parasympathetic neuron, which is efferent in this case, which then goes back to the bladder. Now the stretch receptor is the receptor point. This is the afferent. This is the integration. This is the efferent. And the effector organ in this situation is the detrusor muscle, which contracts. What I've just explained to you right here is the reflex arc. This reflex arc will come in very handy when at the end of this lecture, we'll be discussing the clinical scenarios. Okay. Right, so you have understood what is the reflex arc of the micturition reflex. This is that reflex arc. All of the components of this arc need to be intact for it to work, okay? And finally, this whole thing, if it leads to inhibition of the external sphincter, then micturition will lead to voiding, okay? So we have completed this concept. Okay. Now this is the systematogram. So basically, first you need to understand what kind of a graph this is. This is a pressure volume graph. You would remember that you had a similar sort of concept in lungs when we were discussing compliance. Compliance is also a pressure volume graph. Then heart. So in heart, you also studied a pressure volume diagram to understand how during diastole pressure changes within the heart, and how the same happens during systole. So it's important to understand that hollow organs they can be studied, and they are indeed studied in physiology using these graphs, the pressure and volume graphs, where we introduce a slight under experimental conditions. We have baseline values. If you remember the compliance diagram, we deflated the entire lung, then we inflated it bit by bit by introducing air and plotting the corresponding pressure change, right? This is exactly the same. So you pass a urethra up, or you pass a catheter up the urethra, you empty the bladder, and then you introduce through the same device, you introduce incremental amounts, 50 ml each, of fluid inside the bladder, and then see the corresponding change in pressure. So if you observe, you will see that there are three components to this basal systematogram. One is this bit here, the initial bit where the increase in volume led to some increase in the inside pressure. Then you have a sustained introduction of volume with little change in pressure. And then around this point here, rather 300 and above, you have any change in volume will have corresponding increase in pressure. So the curve starts to go up, okay? If you just concentrate on the thick red line, I've just explained to you the three components. This is one component, which is a increase, is a direct proportion between volume and pressure. Then you have a flat area where volume is being accumulated. So this is basically where the initial part is, where the bladder is completely deflated, and you have just introduced some volume in it. So that will register as an increased pressure. However, since the detrusor is arranged in such a brilliant manner that it rearranges itself without much increase in the pressure on the wall of the bladder, as explained earlier, you will soon enter a phase of flatness on the volume curve. This is where detrusor's architecture is allowing fluid to accumulate in the bladder, however, not at the expense of too much pressure. It's only after an optimal we are now nearing the bladder capacity, which is around 500 ml really. It's around 300 where the bladder wall is now taut. It has enough volume. It's now taut. And now when you add more volume, and if you don't void, then you're adding more volume. Now it will register an equivalent increase in the pressure as you increase the volume. Okay, so this is where the direct proportion or more direct proportion takes place between volume and pressure. And beyond 400, you're really asking for it. This is really steep and it goes up. Okay, so having done this, what are these dotted lines? Okay, you probably guessed it right. These, and it's written there as well, micturition contractions. So around 150, 100 to 150, things are under control. No excitement, and nothing much is happening really. But beyond 150, when you go beyond 150 ml approximately, you stretch the bladder in an enough manner that it will trigger the aforementioned micturition reflex. So before 150 ml, you won't feel the urge to do anything. But beyond 150, you will feel that slight funny feeling that, something is happening down there, right? So beyond 150, what happens is basically the stretch on the detrusor comes up to an extent that it triggers the reflex, the micturition reflex, which then is basically sudden going up of pressure, sustain, and then dropping back to baseline. And we talked about it, that it's incremental, and it's self-regenerative, and it's incremental. So once you have triggered it and you haven't emptied the bladder, the second contraction will be higher, the next one will be higher, the next one will be even higher, and you can see that it just goes on and on. Beyond 400, it's actually painful as well to keep the bladder full and on top of that, you are having all sorts of strong micturition contractions on a full bladder. Okay, so it is painful if you don't void it, and you keep on going to the maximum around 500 ml volume. It is associated with pain, and if memory serves me right, that pain is transmitted through the sympathetic. So you may want to add that third bit to the sympathetic functionality. So these are the micturition contractions which get triggered after 150 ml of the intrabladder volume, and the pattern is very clear. This is micturition reflex for you, the self-regenerative incremental in pattern. This diagram is basically used clinically to study the pressure volume relationship in your patients of various kinds, and the shape of the diagram shows the internal working of the bladder and the micturition reflex, which indirectly shows you the circuit uh, integrity of the reflex. So whether the connections are working fine or not, you can just plot this diagram and see how different it is from the normal diagram. And you infer all sorts of information, valuable information on your patient. Okay, this is that same diagram which we showed you in the functional anatomy part, but this is now the fuller diagram, and it basically I wanted to show you the whole facilitation and inhibition side of the brain, and how it really dominates the bladder and the micturition reflex. So basically, it's described that it's a learned reflex in adults, not in infants. Infants is just gravity-based voiding of the urine. But as you develop, as you myelinate those nerves and you develop the micturition reflex and you develop the CNS, and then CNS is facilitatory or inhibitory signal coming down on the sacral segments, and hence its influence on the micturition reflex develops. You sort of then call it a learned reflex, in which the boy after 3-4 years, he or she now understands when to go to the loo, and when it's not appropriate. So holding on to holding on on urination at lower volumes of bladder is really something that you learn, and hence we say that's a learned reflex. How to use the higher centers to influence the emptying of the bladder. This is something that you learn along early life, and then later on as well. That's why we call it a learned reflex. And in most of the day, when you're out and about, it's the higher centers which keeps this micturition reflex inhibited. It's like in an arrested state, and it's let go only when you want it. Okay, or you're silly enough to keep postponing the inevitable, and then it goes up to 400 and beyond, after which it will have, obviously, it will compel the person to visit the important area, as we say. Okay, so the urine storage, look at this. The urine storage, he has given two flow charts. One is this, correlated with this diagram. The urine storage is when the cortical inhibition means the inhibition exerted by the cerebral cortex and its associate areas in coordination with the pontine center, is basically stimulating the sympathetic neurons, which we mentioned that it's the sympathetics which are pro-filling. So they will relax the detrusor and allow it to fill. And at the same time, stimulation of the somatics, the pudendal nerve, to keep tight contraction of the external sphincter so nothing leaks out. Okay, there obviously is no mention of parasympathetics because this is a urine storage mode. Now switching to the bladder emptying mode. So cortical inhibition turns to facilitation, and it's all you. This is you. This is your consciousness. This is where you control everything. Okay, so now from inhibition, you switch to facilitation along with the pontine areas, which then inhibit the somatic neurons, which relaxes the external sphincter, stimulates the parasympathetic neurons. So powerful contraction of the detrusor, which basically are the micturition contractions under the parasympathetic control. They are then allowed to quote unquote express themselves. Okay, since the external sphincter is now relaxed, contraction of micturition contraction and the detrusor will cause urine to flow out, which is called voiding of urine. Okay, so this is a nice diagram which gives you the overall functionality of how the whole circuit upstairs, quote unquote, affects downstairs. Okay, and you can start imagining that if you were to lose uh, any lesion which is above the sacrum, so if you have a clean cut of spinal cord in an injury which cuts off the spinal cord into two, the sacral segment and the lumbar segment are now separate. The sacral segment is basically independent of any down flowing signals from the higher centers. You can imagine that this independent unit now will function not normally. It will be a funny business going on, and we'll talk about that in a bit. Okay, so this is it. This is the last section of this lecture, the micturition abnormalities. Now remember, this is the oft asked in assessment, in vivas, in SEQs, and in MCQs, in all formats. This is where the urinary bladder, as far as the subject of physiology is concerned, you'll be asked basically uh, high probability that you'll be getting questions from the clinical abnormalities, this slide onwards. Okay, so it's basically all you have to remember really is the reflex arc. We mentioned that the whole thing starts with stretched receptors, which are the receptors of this reflex arc. Then you have the afferents, which are sensory nerves traveling in the pelvic nerves, anatomically going to the sacral segment. Their integration happens, interneurons are activated, which then lead to the signal leading to efferents, which are basically the parasympathetic fibers. And they are the motor fibers in this reflex arc, the efferent motor, as we say, and they go to the reflector organ, which in this case is the detrusor. Just keep that reflex arc in mind. And a footnote: there is no mention of sympathetics. Okay, so the lesions will be on three lines. What if afferents are cut? That's scenario number one. Scenario number two is what if you cut both afferent and efferents? Okay, and three, you keep all of this intact. So so the reflex arc, the basic arc, the spinal segmental arc is intact. However, the descending pathways are severed, which I mentioned just a while ago. That any lesion completely transecting the spinal cord above the sacral region, sacral spinal cord, will interrupt those facilitatory, inhibitory signals, very important ones coming down from the brain. And you can infer quickly what will happen in this case. So moving on to lesion number one, it's called deafferentation. So it's the selective damage of sorts to the afferents only. Very quickly, let me just start from the bottom. In syphilis infection, you have what we call a tabetic bladder. So this is an infection which basically affects the dorsal root. You know that the dorsal root of the spinal cord is where the sensory information comes in. This is the rule of the spinal cord. Dorsal sensory information enters the spinal cord through the dorsal horn, and the motor output of the spinal cord is basically through its ventral horn. Okay, so there are some diseases, infective diseases, syphilis being the most famous one, which affects the dorsal roots primarily. And hence it basically messes up the sensory afferents of the bladder, along with a plethora of other issues. But since we are discussing bladder, so the bladder gets deafferented. Okay, then there are some specific crushing injuries. It's rare that a crushing injury of the pelvis would just take out the afferents. Usually it's the entire pelvic nerve, which basically means afferents and efferents. So when we'll talk about scenario number 2, crushing pelvic injuries come on top of that. Here, if somebody asks you, you can mention the selective dorsal root lesions, and syphilis comes to mind in that. So what happens in deafferentation? Reflex contraction of the bladder abolished. You studied this when you were little, actually, in the early classes. That reflex arc is the basis of the functioning of a reflex, and if you interrupt the reflex arc anywhere in its pathway, the reflex cannot happen. Simple, simple. So you have taken out the afferent. Obviously, the reflex will not happen. Okay, it will be abolished. What happens to the bladder? Well, you obviously are not stopping the urine. It keeps on collecting, distending the bladder. It becomes thin-walled, hypotonic. Although there are some contractions which are based on the fact that smooth muscle, when stretched, does try to contract. So these are not micturition contractions. They are just tonic contractions. This is a habit of smooth muscle. So when the whole system is flooded with urine, the capacity is overridden, and droplets then tend to overflow. We call it overflow incontinence. So the person has no micturition reflex going on. The bladder is over distended, and overflowing of urine happens, and this person becomes incontinent, which means that he has to let go of the external sphincter to release the pressure on the bladder. It's not graceful. It's not social. It's basically a messy situation. Okay, so that's that. Then you have those crushing injuries, which takes out the entire pelvic nerve. So both afferent and efferents go. We call it denervation. So basically, you've studied this word in terms of in relation to muscles. When the supplying nerve gets cut, we say that the muscle has been denervated. So this is that denervation. The bladder again becomes flaccid, distended for a while, but then it becomes a bit active, which is interesting, expelling dribbles of urine out. This eventually it becomes hypertrophied, so it becomes so active that it becomes hypertrophied and shrunken. It's like a crunched up football. Okay, and this hypertrophy, last time I checked, the cause is not known. So this is the denervated bladder, as opposed to the deafferented bladder, which is distended, thin-walled, hypotonic. You have denervated bladder, which first is flaccid and distended, but eventually it's shrunken and hypertrophied. This is an important distinction to note. Then you have the last part, which is spinal cord transaction. And remember, I mentioned sacral segment. So if you have a sacral segment, suprasacral segment transaction of the spinal cord, first, as you have studied in sensory physiology, sensory CNS physiology, is that any damage to the spinal cord first leads to a spinal shock-like situation. So everything that the spinal cord does goes into suppression. The bladder will go down, flaccid, unresponsive, because all of the reflexes are just sort of switched off. And we are not talking about just the micturition reflex. We're talking about all reflexes of the related spinal cord segment. In the spinal cord, it's generic. Everything goes mute. So together with all of that, you have also micturition reflex, which becomes unresponsive. The bladder gets overfilled. Again, you have overflow incontinence during the spinal shock scenario. However, after spinal shock is over, micturition reflex returns. Now, you may ask, what is going on? We have a very serious injury to the spinal cord, and how come micturition reflex will return? Well, the answer I've already given you is that this lesion is above the level of the sacral segment of the spinal cord, and the reflex is integrated in the sacral segment of the spinal cord. So you don't disturb that. You cut the spinal cord above the sacral segment. So the integrated spinal reflex, which is the maturation reflex, the reflex arc is intact. The whole reflex is intact. Hence, just after spinal shock is over, micturition reflex returns. However, of course, it won't behave very nicely. It will behave as a rude uh, cousin of yours, in the sense that it will do whatever it wants. Okay. There won't be any voluntary control, because voluntary control was exerted by the descending fibers coming from the higher centers, which in this case you have cut. So there is no voluntary control, and very important thing to note, that this deviation from normalcy is there. There is no inhibition or facilitation from the higher centers, and this is called automatic bladder. So what will happen is that, as opposed to denervation and deafferentation, this bladder has the micturition reflex going on, but you don't have any control over the external sphincter. Very importantly, so what will happen is it will run its course, do the micturition, self-regenerative incremental contractions, and that will just the micturiation will be triggered, the reflex will be triggered, and it will be immediately followed by urination. So you can imagine that there is no conscious control of urination, because you've lost all that. So this is automatic bladder. It has a mind of its own, and it's on automatic. Lastly, there are some higher center brain damages, like head injuries, cancerous growths in those segments of the pons where the micturition center sits, or the cerebral cortex itself, or strokes which cut off the blood supply. Whichever way, if there is brain damage in the areas which control micturition, higher centers that is, you have a situation called spastic neurogenic bladder. Okay. These are terms which you need to look up and remember, because these are the terms which are used in your assessment. An examiner can simply ask you what is an automatic bladder. You have to come up with all of this. Okay. The examiner can ask you overflowing continence. When do you have this? You will say deafferentation and during spinal shock of uh, spinal cord section. Um, so in that context, spastic neurogenic bladder is when higher centers get affected, get damaged. The bladder the whole bladder again becomes a hypertrophied, shrunken, contracted organ. But the reason for this is basically because of the overdriven micturition reflex, which in this case is automatic, and there is nothing to stop that. And it's the whole spasmodic picture that you get in any upper motor neuron lesion, as you have studied in motor physiology. Okay. So that's that. These are the references. This finishes off the first chapter, the second chapter of Guyton. The first was the body fluids. The second is related to nephron, glomerulus, i.e. GFR. And now it finishes off with micturition. Remember, this chapter packs a lot of information. So do take your time in reading it and properly understanding it, correlating it with these videos, and performing actively in your tutorials. Okay, thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.